Okay, so let's get started with a video from Jamie talking about the care crisis. Bear with me while I share that again. Welcome, everybody, to this Pathfinders event on planning for emergencies. Just to let everyone know that if you're a panelist in the webinar, then I will move you over at the appropriate time. So this event is going to be looking at all the things that can go wrong and how we prepare for them. So it's those kind of things that you don't really want to spend too much time thinking about, but it's good to have everything like in place. You can and kind of having things planned so that you can kind of relax and get on with your life. Really. So yeah, today we're going to be looking at things such as how to cope when your care package breaks down. So if you have problems with carers and PAs, for example, going off sick, and how you kind of prepare for that. We're also going to be looking at ventilation and kind of what you can expect from ventilation, your ventilation needs, and how to manage these. And particularly how to prevent kind of emergencies occurring where possible. Then we're going to be looking at how to manage if you have to go into hospital. So hopefully we don't have to do that too often, but it's good to know kind of how to prepare for this when that can happen. And then finally, we're going to be looking at talking to James from My Wishes and hearing about how we can plan for end of life and also just for getting the right kind of care plans in hospital and kind of just making sure that everything's in order. So again, so you can just focus on living your life really. So we're going to be starting off um, with the kind of care crisis stuff. Just to note that we are going to be recording this webinar, so just so that we can play it, add it to YouTube, and people can watch it at their own convenience. And we're going to be doing that throughout the webinar. So if you're a panelist, just to let you know that you will be featured. Okay, so
One of the big steps in becoming independent is starting to manage your own care package. But being reliant on one's care team means having contingency plans in place for when things go wrong. Ultimately, for you, it's your life, but normally for them, it's a job. And that means that people will be off sick or absent or leave the job at a bad time. And you have to have a plan in place for managing that, or you risk being stranded. So this section is about having a care contingency and how that works for me. My name is Jamie Hale, and I'm one of the CEOs at Pathfinders and also work in theatre and writing, so I keep busy. I've been managing my PAs and care package for a decade, with the care package changing a lot in that time, from 28 hours a week at uni when I was more independent, through my package increasing as my needs did. And then about 3 years ago, I moved across to funding from NHS continuing healthcare, by which time I had about 84 hours a week. About a year and a bit ago, I was given 24-hour care after a long hospitalisation triggered by a pressure sore that should have been avoided. During this time, I've probably employed about 50 people, though checking would be quite a challenge. This is because I've employed everyone from students to clowns, no, really, an actual clown, she's great, to career carers, and all of them have had their advantage. For some people, maintaining a really stable care team across years and even decades works better, but I've always quite enjoyed the freshness of swapping out, even if it means lots of training. I find the people I employ all over the place. Carers who hated the rigidity or the speedy visits of agency work, people who found the job on Indeed, healthcare students, or even posters on trees. Once someone has applied, I send them a list of questions that are mostly yes or no and wait for their replies. Once those come in, I interview people currently over Zoom. If they seem plausible, I invite them to watch a shift, which, if they then get the job, they will be paid for. After that, there's paid training, and then we get going. I don't prioritize people with experience. What I want is people who are willing to learn, people who are comfortable with personal care, and having enough people to cover all of my shifts. So that means always trying to make sure that I've got one or two more people than I need to cover all of my hours, so that if someone leaves or even goes on holiday, there's always someone else who wants to take over the hours. I don't always manage this, but it's a key part of my contingency because it also increases the chance that there'll be somebody available at short notice if I need to cover a shift and my backup, more on that later, can't make it. I try to keep my rota as predictable as possible. The rota comes out in 4 weekly blocks and it's set up using a spreadsheet. Shifts vary from 10 to 24.5 hours, depending on my plans and the person working. Because people know in advance what their shifts are likely to look like, this lets them plan their lives ahead and means that they're more able to commit to their shifts. For every shift a person is given, they're also given one backup shift. This backup shift is a shift that they cover if the person working it happens to be off. So if someone calls in sick, I just call the backup. And people don't make plans on a backup day that they can't cancel at short notice. But this, of course, means that they know that they're guaranteed those extra hours if the hours become available. I began this at the start of the pandemic and nobody had any objections to it. So while I don't know if it's something that I can continue post-pandemic, I fully intend to. As well as a backup rota, with someone mandated to cover each shift if the person isn't in, I try and keep a good, positive, collaborative atmosphere. I make sure people know that I appreciate them and what they do, and I find that atmosphere very worthwhile indeed, making it far easier for me to cover shifts when I need to. If the team atmosphere is tense or it feels like someone isn't pulling weight, everyone else wants to slack as well, which makes things far harder. However, sometimes things will still go wrong, and you do need a plan for that. If all of your regular PAs can't come in, you need a friend, a family member, or someone else you can contact. I found that that person doesn't need to know everything, but they need to know the absolute essentials required to keep me going. They won't be meeting all of my desires, but they'll know what they need to do to keep me alive. One of the things I've done for this is made sure that I've got videos recorded of everything important. So if someone is stepping in at short notice, there's a video that explains how to carry out all of the essential tasks. Most of the time you won't need it, but if you do, you'll be very glad to have it in place. For people with support from places like hospices, they're also often willing to be a backup if everything goes wrong. And while it's really hard to know that you'll be stuck having to ask someone to do something like that, it's worth knowing what you're going to do if you end up in that situation. I've always found planning for emergencies is something that it's better to overdo than underdo. Or as the quote goes, fail to prepare, prepare to fail. And I've made my share of mistakes, but now I've got a solid contingency. When people are off, people can cover them. And if it all goes wrong, I've got people who can step in. It's not easy to build that. It's not easy to maintain it, but it's thoroughly worth it. Thank you.
Okay, thank you to Jamie for sharing that. It was really useful. I'm just going to bring our first panelist, Reese, up to the front.
My name is Rich Boner. I live in the Southwest Valleys in Toiletries. But I live on my own independently. To me, independence means everything. It means the world is the very reason why I exist. I couldn't live with my parents anymore. I couldn't be under anybody else's rules. To me, independence represents true freedom. I'm not like you. Living on my own has presented some major challenges, particularly when it comes to care plans. We all experience different individual stresses, such as carers sometimes not turning up, interviewing staff, teaching them how to care for you, training, in particular house training, all them sorts of problems. But despite the problems I have had, I would not sacrifice it for the world. The training sometimes can be very difficult, as in with agencies, you tend to have several different people who you've had to train. For example, I've been with agencies and ended up having to train about 20 staff, to which I would never see again. So agencies for me would not be the way to go, which is why I choose to go independent. Now, the problem is, in Wales, is that there are very different forms of care throughout the UK. Though most of the times, giving them for example, they are PHPs, personal health budgets that are available which taught me inspire people to live independently. It's not the easiest way, but it's easier than it is in Wales. The issues we are presenting here in Wales is if you have a medical need, you have to go to the NHS. In going to the NHS, they supply you with an agency. So in fact, you lose an entire freedom and control. The way the PHP is great is that they give you the money directly straight from the NHS. The really Wales, there's a constant battle between social and healthcare to both argue over who's going to pay for your care. Now, this is quite distressing, as it's left me with a lack of 24-hour care. And anybody with a condition or an advanced medical condition can see how much we struggle with that 24-hour care. So there's a clear need here in Wales for that. Now, as I mentioned previously, independence means everything to me. I have literally bled, sweat, and cried over it. I've had incidents of lack of care where I hurt myself in a hairdryer because nobody's turned up. I was left in agonizing pain. Now, to me, that should have been a wake-up call for the authorities. But they didn't wake up, and I've been this way for 20 plus years, in need of 24-hour care and not having it. Now, the idea of independence to me is an amazing thing. I mean, people fear it, right? But you shouldn't feel it. It needs to be championed. It's the most positive thing you can possibly have. I mean, as a disabled person, we shouldn't be different to anybody else. We should have the opportunity to have sex, to have relationships, and not live under anybody else's rules. I mean, if you want to live with your parents, fair enough, but surely every man, woman, and person has the right to want to live on their own. I mean, it's the only way we can achieve futures, to get married, to have children. It's the only way that's possible. And for this to happen, the PHV needs to be available all over the UK. Currently, it's only available in England and Scotland. And Wales are being left out. And for some reason, they refuse to change. And it's entrapping me even further than my disability. So, if I had the care that I needed, I could go out, I could achieve relationships, I could go on holidays, for example. So I could have all these wonderful things. So, for this to happen, the Welsh government really needs to enforce a PHP.
Yeah, that's great. Okay, cool. Well, that brings us to the end of this section. We're going to now be moving on to talking about ventilation. I'm just going to bring up the people that are going to be on the ventilation panel. So bear with me a moment. So we're now going to be talking about the ventilation journey and just hearing from a few people about their experiences of moving to different forms of ventilation. I'm going to just start giving a short presentation about my own journey, and then we're going to be hearing from Bobby, and then moving on to our ventilation panel, where we're going to be putting questions to them about ventilation. So please add your questions in either the Q&A or the chat, and we will put those to the panel. So I'm just going to share my screen and share my presentation. Okay, so yeah, about my journey. So I used non-invasive ventilation first overnight, and then I just gradually started using the non-invasive ventilation more and more. I think I started it overnight. It was in my early 20s, which now seems like a long time ago. And yeah, just gradually started using it more and more, and it just became quite a bit of a challenge trying to guess when I needed it during the daytime and trying to get that balance right. And I then went to 24/7 ventilation a little bit, maybe I said early, but I mean I was still able to manage maybe 2 or 3 hours off the ventilator in the daytime, but I was kind of just feeling a bit like I was lacking in energy, loss of appetite, and that kind of thing. And I think when I got to that point, I was pretty much just decided to just go ahead and do it 24/7, and I'm glad that I did because I felt I had a lot more energy and appetite after that. I was then the kind of guinea pig for SIP ventilation in my ventilation clinic that I go to. They've never done it before, so now I have a combination of the SIP mouthpiece ventilator as well as the nose mask that I'm using at the moment, and I kind of alternate between those. And now I would say my health's quite stable, and I'm certainly open to getting a tracheostomy when I need it, but at the moment I'm not planning on doing that preventatively. I'll get that if I need it, if I become unwell or frequently get chest infections or something that indicates that I would need it. But other than that, I just try and prevent getting coughs and colds and just treating infections early, having a course of antibiotics at home, that kind of thing. So yep. So the previous picture is just me using the mouthpiece ventilation, which I do find useful. It's got its own limitations though. Like if you're talking a lot, then it's a bit more difficult to manage with the mouthpiece. So that's why I use the nose mask for things like this. So starting on the non-invasive ventilation overnight, we are talking quite a while ago now that I did it, but I found it was just a case of kind of working up to it really. So when I left the clinic and they gave me all the equipment, it was just kind of like get used to wearing it, sitting in front of the TV and just wearing it just to get accustomed to the feel of it really. Getting the mask right, that's a challenge. I went through quite a lot of different masks at the beginning to find one that really fit correctly. And that's something you just have to kind of go through really. And then just kind of like thinking about what might go wrong. I mean, you need to kind of make sure that you've thought about that. So, what happens if the ventilator tube would disconnect, for example? There's an alarm that would alert someone to help you, but if you can't actually physically say reconnect it yourself, then you need to make sure that there is somebody there who can hear it and will actually respond to that. So you do need to kind of think about that kind of thing. Dealing with sores, that was the main thing for me with the mask. So that was just about getting the right mask. It was just quite caused like pressure sores on my face and that kind of thing. And getting it sorted early, really. Like if you are starting to get sores, just you need to do that and deal with that immediately. And getting the pressures right for you as well if it's causing other problems. And yeah, I think the main thing is the tricky part can be the transition period between using ventilation overnight and using it 24/7. And just you have a period of time where you can manage without it, but you need to kind of have regular monitoring really, and ideally at different times of day so that you know what kind of the CO2 levels are, not just in if you go to a clinic in the morning, um, they won't pick up the levels creeping up in the afternoon or evening. Also, you're more vulnerable to infection and other problems while you're kind of not breathing like fully, when you're trying to manage without it. But you also need to make sure you get the equipment ready for the transition to 24/7 ventilation. So, for example, being able to carry the ventilator on the back of the wheelchair is really important to actually being able to still get out and about. And if you're not ready for that, then you might put off transitioning to full-time ventilation just because you don't know how you'll stay independent. So it's important to kind of get that sorted really. And it's not only a respiratory function issue, it's also about like appetite and energy as well. And the benefits of permanent ventilation is you have more energy, better appetite, less anxiety, I would say, about kind of struggling to breathe. Certainly, for me, I found I had improved swallowing and louder speech, and you are also less vulnerable to infection. Um, some of the challenges of adaptive permanent ventilation is you have to kind of figure out a solution for things like eating with it, showering with it, just like cleaning your teeth, having a shave and a haircut. I find it's really useful to have the mouthpiece and the nose mask because I can switch between them depending on what I need to do. Being intimate is another one. Um, so all of these things can be done if necessary, but the mask makes it a little bit more tricky. So it's quite that mouthpiece ventilation is quite useful. So the thing with the mouthpiece, it takes some getting used to, and you might need to try different ventilator modes. You also need a way of mounting it to the wheelchair. There are a few solutions to that. I've got a kind of ventilator arm of flexible tubing that you can see that kind of stays in place and fixes to the wheelchair. Easy to just pop it out your mouth, put it back as you're dressing, and kind of doing things like when I'm wheeling from my bedroom to the shower, then I just take it off for like 30 seconds. But yeah, it doesn't necessarily suit all situations, as I mentioned. And the challenges, just to conclude, the challenges of mouthpiece ventilation is it's not quite as good as a trachea for dealing with infection. So you need to use a cough assist, and that can be quite tiring and exhausting. Whereas with the trachea, you can just do the suctioning easier. So when you get ill, it's easier to deal with it with a trachea, I think. Then the other main challenge is not everyone gets on with the mouthpiece ventilation. It can take a bit of getting used to. You've got to learn to breathe with it. It's a bit of a technique. So yeah, it really it's not necessarily for everyone, but that's what works for me. So yeah, that's just my experience. So I'm sure other people will have their own experience as well. And we're gonna move on now. We're gonna hear from Bobby about his experience with ventilation and getting a tracheostomy. So I'll hand over to Bobby.
Yeah, cheers, John. Yeah, so I'm Bobby. I've had a trachea for 2 years now. It came about after having a chest infection in hospital, where I choked on a mucus plug and went into cardiac arrest. I've wrote an article about that for Pathfinders actually, which explains all the things that were going on. So yeah, I want to say that overnight ventilation is okay and I sleep better and stuff, but I really don't. I'm constantly waking up during the night needing suction, so I do get tired quite a lot. I'm trying to work on that and currently doing something about it. But for me, the secretions are the most important thing to manage. As when you breathe normally, the air you're breathing is warmed and moistened. So the air you breathe is clean and warm. And through a trachea, you don't get that. So this makes the air you breathe cold and dry, makes the secretions thicker, so harder to clear. And my advice there is just keep on top of secretions, use frequent nibs to loosen the cough assist regularly to shift it. You know, it's important to keep on top of infections as well, to send samples off if there's a change in the colour or they're thicker than usual. And if it, so send samples off, and if it is an infection, get some antibiotics early on to deal with it. The important thing is just to keep on top of infections and secretions and manage them so they're easier to bring up. And yeah, that's really all I've got for that.
Great. Thank you, Bobby. That's really useful. And I would recommend everyone check out Bobby's blog that he wrote for Pathfinders. That's some really useful insights and information, particularly for people thinking about whether a trachea is the right option for them, and you know, what the process is like. Great, thank you. So we're going to move on to the ventilation panel. So we've got with us John Ashby, Johnny Housley, and Sam Strickland have joined us as well, and they're going to be sharing their own experiences of ventilation. So just to give some introductions, so John Ashby is one of the original Pathfinders, and he's been on ventilation for a number of years and has a YouTube channel as well. And Johnny Housley is happily married and specialises in disability support, and has been receiving ventilation care since that age of 16. And Sam Strickland has been using non-invasive ventilation for 8 years and is currently fighting alongside Reese to get their PHPs in Wales. So welcome everybody, thank you for joining us. So if we want to move on to some questions for the panel, please do keep these coming. I have some that we received earlier. I wanted to ask people if they have any advice for people who are just starting out on ventilation. So that probably means just starting overnight, having it. Do you have any advice for people just starting the journey? How about we start with Johnny? Do you want to go first?
Yeah, hello. One of the bits of advice I'd recommend is just like someone mentioned before about finding the right mask that's comfortable, that doesn't feel very restrictive. Because sometimes going straight onto a full face mask, I know when I first tried it, it felt a bit like a bit stuck with it on your face and a bit trapped. So it can be a bit overwhelming at first, and just starting off with the pressures and just slowly increasing it as you see fit with the help of your ventilator team as well.
Great, thank you. Sam, do you want to?
Yeah, well, I was scheduled to go for my mask fitting and start nib, but I actually went into respiratory arrest just the week before I was due to go in. So a lot of my first weekend with the mask, I was unconscious in ITU obviously broke up. Yeah, they started with the full face mask. I couldn't really cope with that. So we went on to the nasal mask. I coped pretty well with that. It gets a bit uncomfortable overnight, but I've got one that fits. Occasionally we still have problems, but it's okay. And then I've got my NIV during the day. So I'm glad I've got the SIP during the day, just so that I can get a rest from the mask. But yeah, it's worked out pretty well. My team's pretty good. Wrexham.
Yeah, that sounds good. And do you have any advice for people kind of starting out who might be feeling a bit nervous about doing it?
I think if you get into it early, you can try the masks. It is trial and error, I think, and just see what suits you. Some people are going to prefer a full face mask. Some people prefer the nasal. I think it is trial and error and having a team that's willing to find the right mask for you and give you the options, really.
Great, thank you. And John Ashby, how about you? Do you have any advice for people?
Well, I wasn't lucky enough to be able to try a mask because I ended up unconscious and being rushed to hospital. And they put me straight onto a ventilator. So basically, from there, that's what I've been on ever since. I'm now have a trachea. So I've had mine for nearly 20 years now, the trachea. So I didn't get a chance to have a mask. But what I would say is, for people to get onto it early, so they don't have to be rushed into hospital like I was. So that's the only advice I would offer. So.
Yeah, that's really good advice. I think just for people to make sure they're getting their breathing function checked regularly, so that you can kind of identify any issues before it becomes an emergency. That's a really good point. Thank you. Bobby, was there any advice you wanted to share?
No, because of the situation, they just put me on the ventilator from basically waking up, and then they've decided I'm ventilated overnight. So I can't really give any advice because it's more like I didn't have a choice.
Right.
So I have that in place. I really ultimately just try to keep on top of infections and not in that situation in the first place.
Great.
Fortunately, you know, it's unavoidable sometimes.
Yeah.
Yeah, that's what I'd say for that.
But yeah, that's a good point, definitely. Okay. Right. So another question is just about to people about what support you receive from your ventilation team. So it's quite useful for us to identify what might be considered best practice. So yeah, what support do you receive from your clinic and from your team? And is there anything anything that really works well? We'll go back to Johnny on that one.
Hello. I've been with different ventilation clinics over since I started on mine when I was about 16. For one of the good things with the Northwest one, or when I was under Newcastle's care team, is that they offered appointments quite regularly, and they'd offer support with getting my mask sorted and suitable, and they'd offer quite a lot of time and patience for getting setups right, so when the pressure wasn't too much. And then they do overnight checks as well, where they could keep an eye on it to see if anything changed. Because the bit I found is that whenever there's a issue with my breathing, it never showed up at the appointments. It would always be at random times, even when I was asleep. So it's quite good in regards to picking anything like that up. and now I'm in Manchester. The clinic's quite good in a way that we get a lot more supplies to me next day delivery, and I can always arrange to pop in if there's any cancellations, and getting advice on the phone is quite easy. But one of the good bits of advice they gave me, it's kind of like Bobby was saying before about trying to prevent infections and just being ready for them, is I get a dry mix of antibiotics as a powder. So then my care staff can just make it up with water whenever I get it. So I'm not having to wait for it to be prescribed or get a prescription through, because with antibiotics, I know it's always good to start them as soon as you're aware of a chest infection starting. So that's one of the bits of advice they gave me that was good.
Great, yeah, thank you. I think that's a really important point about you know, being able to check things overnight as well, because yeah, I always found, you know, when I went to the clinic, it was kind of like middle of the day, but that was never the time that I felt that I wasn't getting enough, like or that the CO2 levels were building up. So it's kind of important to be able to test it like at home as well.
Yeah.
Or overnight in a sleep study, yeah.
Yeah, because the oximeters are quite a useful gadget I've found for giving early signs of any issues that you can do at home.
Yeah, definitely. How about you, Sam? Has there been really good support that you've received?
Yeah, my team is really good. I've generally got appointments every 6 months. It goes to 3 months if any issues arise. I have a night study to do before every appointment. That's usually when they find something. I've got an email to my NIV nurse and a number. And second, I have any issues, I just message them. And they're quick to help out and sort things. I get my supplies sent out straight away if I'm needed. And yeah, they've been really good.
Great, that's good to hear. And how about you, John?
Yeah. Yeah, I'm under Leicester, England, Glenfield Hospital. I go to their chest clinic, and they're really good. I tend to get an appointment like every 6 months. But during the pandemic, they actually come out to the house to test my blood gases and things, which I think is really good. So they come out like that. And if I need anything with the school, we can just call them. And they're usually quite helpful. So. And they do send some equipment if I need anything, like tubing or things like that, they send. And they do ring during this pandemic. They've been ringing to see if I'm okay.
Great, that's good. That's good to hear. And Bobby, was there anything you wanted to add to that in terms of you know, the good kind of care that you receive? Is there anything that particularly stands out to you?
Yeah, like everyone says, I also have 6 monthly appointments to see him. My advice is don't wait every 6 months to get in touch if you've got a problem. If you're getting headaches or falling asleep during the day, just get in touch and they're pretty quick to sort problems like that. Yeah, basically just get in touch with them. They're really good with me. That's pretty quickly, so yeah.
Great, thank you. So we've got a couple of questions from the audience. Sarah asks if anyone has any tips for dealing with sore nostrils from wearing nasal pillows. Any of the panel that uses nasal pillows, have you got any experience to share?
I've used nasal pillows a bit in the past, because in winter I have a full face mask and the rest of the time just a nasal pillow one. think mine's a Swift LX, I think. And sometimes when I've had a sore nose, it's been a case of pillows under my nose are either too big for my nostril and it just stretches it a bit. And usually I've swapped to a smaller one and that's helped. And then through the day, as I've heard some people use aloe vera, which I've tried a bit just to make your skin a bit better afterwards. But it's not for everyone, but that's a bit I could offer.
Great, thank you. Yeah, I mean, I'm currently using nasal pillows, and I do get experience some soreness from time to time. It's fine, particularly when they're new. They're much firmer than when you've been wearing them a while, and I think that can irritate your nose. So if I get new ones, then I have to kind of like switch between like the kind of the older and the newer pillows just until you kind of like break them in a little bit. But they also find the mouthpiece, just getting off the nasal pillows for like an hour or two can make a big difference in just making it less sore. Otherwise, yeah, just kind of keeping things moisturized. Like I found I used to get a lot of like sores and stuff, not just from nasal pillows, but from other masks as well. And actually keeping my face moisturized twice a day has helped immeasurably with that, which just quite a simple thing that you can do. Okay, we've got another question about cough assist machines, and from one of our attendees who's respiratory team have declined one. Just wondering if people have cough assist machines and what your experience of getting these have been.
I have a cough assist, but I managed to get Leicester to order mine for me through my CCG, and there was no problem with getting it at all with my local CCG and stuff. I know some people get refused, but I didn't have any problems. But it is needed though. But I think it's a vital piece of the equipment that I use, I think. I wouldn't be without it. No, I don't think.
Yeah, that's great. Thanks, John. Yeah, I agree. I wouldn't couldn't be without mine either. It's like a lifesaver really. I think if you probably go onto YouTube, you could probably find me on a video talking about the importance of cough assist somewhere. This was like almost probably about 10 years ago now when I was trying to fight to get access to the cough assist myself. And yeah, that was a fight. But I mean, it should be better these days. Like more clinics should be providing them, but we can certainly help with anyone having issues accessing those. But yeah, I rely on it completely. Cool. Anyone else? Sam or Johnny, do you use cough assist?
Yeah, I've had my cough assist for about 15 years. It was the first bit of equipment they gave me. I've still got the same one. It badly needs updating into the new model. But yeah, I've just used it every day. It's kind of as physio, if anything. If I've had a cold, it helps tremendously. But every day I just try and do it. Make sure everything's okay. Everything's coming up as it should do. But it was the first thing offered to me. I don't know why that wouldn't be offered now. They should be able to get it quite easily, I think.
Yeah, definitely.
I've got a cough assist machine, but I probably don't use it as much as I really should. But I do generally use it when I've got signs of a chest infection or a cough coming on, just to help give it a bit of an extra boost. because I used to have this big massive one with dials, and I just swapped it to a clear way. I've got one of those now, it's a lot better because when I used to have the old one that had dials, once I was being transferred in an ambulance and the machine got knocked and the dials got changed, so it ended up on a high power, so I came to use it, almost blew me up. So the new one's a lot better. It's a lot safer, but I don't use it as much as I should. I use it more than I used to, but I haven't got as much experience as everyone else with it.
Okay, thank you, Johnny. That's really useful. So we're coming to the end of the panel session now. So I just want to say thank you to all our panelists and to Bobby for your talk earlier as well. And if there's any more questions, then please keep them coming, and we will get to them where we can. Great, thank you, everybody. Right, so okay, we're joined by Sarah, Sanjeev, and Andy at the moment. So
Yeah.
do you want to just introduce yourselves? So Sarah, do you want to introduce yourself?
I am Sarah. I live down in East Sussex. I have Corrick, Sydney. And I've had a few emergency admissions in the past as well as planned hospital stays. So I've got a good idea of things to take and what you need to make it the best possible sort of stay you can, given the circumstances.
Great, thanks. Sarah, Sanjeev, do you want to introduce yourself?
Yeah, my name's Sanjeev. I'm a development worker here at Pathfinders, and I have Duchenne muscular dystrophy. I live up in Scotland, so something a little bit different from up here. So I've kind of had a few visits in the hospital over the last month, last year. So I would probably add a bit more about that.
Great, thank you, Sanjeev. Andy, do you want to introduce yourself?
Hi, hello everyone. My name's Andy Rose. I'm one of the neuromuscular care advisors for the East of England, based in Cambridge. My background's physiotherapy, so I'm going to try and fill in any gaps that, if anyone doesn't mention them, about what might or might not go on during a hospital admission from sort of a care provision point of view. So, yeah.
Great, thank you, Andy. Good to have you with us. Okay, so we're gonna start with Sarah. I'm gonna be explaining what's in her emergency bag and preparing for emergency visits. So over to you, Sarah.
Is it alright to share my screen?
Yes, you should be able to.
Okay, brilliant. Bear with me, I don't do this very often. Okay, so I think for me the key to hospital admissions is, well, firstly, being able to have my PA with me, which I believe might be talked about later, but also having the things I need, the essentials and the other things that make the difference between a comfortable stay or more likely that I am to have a quicker recovery. So on the top of my list, this is what I have in my folder that my PAs know where it is. So some of the things from my bag I can't really pack in advance because they're things that I use all the time. So just to be organised, I have my alert card, which is condition specific, in my phone case. I have my care plan and emergency documents, contacts, things about me, my ventilator settings, and emergency contact consultant info. So that's what stuff I can do before. So if I go down, hang on, this could be tricky. So I start with the first divided it into categories. First is medical, which is a bit of a repeat. Some of the things that I've already got in place, emergency details, the things that like advice on administering oxygen or not, if the case may be. How I need to be positioned, things that I might not be able to communicate at the time, and also any medication that I'm on, which at the moment comes to be gabapentin. And then I've got the electricals category, because I'm sure that many of us have a lot of things that the essentials they need. And I put a star against the ones that would probably come with me should I be admitted via an ambulance. So there's my day vent, which I'm sure I'd be on at the time, and any things needed to run that. And my cough assist as well. And then the other things on the list, like my nighttime vent, mobile phone, they can be packed and or with me or bought afterwards, because somebody came followed up with me later. Just going to try and move the page down. Okay, bit too far. Okay, so I say that to do with comfort, they're vital to being able to breathe properly, being able to avoid pressure sores. We all have got little supports and everything that we need. So in my case, I have a mattress stopper because I can't get on with the air mattresses that you get provided with when you're in hospital. Things that are specific to me for moving me around, like slide sheet. I would take my hoist sling. It might not be compatible with hoists in hospital, but it's worth taking because it suits me. It's fitted for me. And things to help me comfortable in bed. Because if I'm in the wrong position, I might be more prone to secretions and pressure sores. And then in blue, these might not be essentials, but in experience of different visits, I've decided it's good to plan for any sort of temperature. I've been in hospital when it's freezing cold and the radiators don't work, and I've been in hospital when it's really boiling and the windows are stuck. So these are just preferred things, but not essentials. Just move down the list. I would probably also take pull-ups with me because toileting can be a problem in hospital. I can't use the usual modes of toileting if I couldn't get to the toilet itself. So I would take something like that just to make life a bit easier. You don't always want to be pulled and moved around a lot. And in green, I put wheelchair, because they don't always take your wheelchair in an ambulance, but it might come on after if it's practical in terms of space. And then the rest of it really is the sort of thing that you would take wherever you go, on holiday or hospital visits. Oh, sorry about that. Things like essential toiletries, dry shampoo is a godsend. Sorry, trying to make the page there. Wet wipes, things to make life easier. Easy clothes. Get extra things because you can't always get hold of them. Things like anti-bac or sanitizers. Really one that's helping me. And then in miscellaneous, I've got straws. I always try to have straws with me. And then in blue again, things that I'd like to have, if possible. So I would like to have my earphones, purse, anything to keep me occupied. But obviously in an emergency, it wouldn't be, what you would think of first. The reason I have this written out is because, in an emergency situation, you need to think quickly, and it's a source of reference for my PAs should they need to gather up things in a hurry. So that's sort of what I do. I'm sure we all have our own versions of this, but I think that's about it from me.
Great. Thank you very much, Sarah.
Do I have to stop the share?
I can do that. There we go.
Okay, cool.
Okay, cool. So over to Sanjeev now, who's going to share his own experience.
Yeah. I think Sarah did say probably quite a few. Yeah, I was going to say, but I can give kind of my thoughts anyway. So basically, I'll give you a little bit of background. Before last year, I'd never really had a visit to hospital. I was always kind of doing okay with appointments. And then starting the beginning of last year, everything just kind of happened, and I was in hospital with an infection. And then it's just one of those things where a year with infection just kept going. So I kept catching different things. And I've been in quite a few times this year. So yeah, obviously it's not the best feeling, but you know that it's going to make you feel better. So yeah, generally what I take with me, on the night I always take essentials, like toothbrush, extra clothes, obviously my ventilator, stuff that's really important, because I think normally the first night I go in, I'm always thinking that I'm going to get out that night. So I always think that I don't need to stay the night. I guess it's just the way I think. So I kind of always kind of get more things the next day. But obviously depends on your situation, how close you are to your house, things like that. But yeah, obviously medicine is really important. Always actually order extra, always have extra ready in a secondary bag, ready to just go. I do that with quite a few things. I've got my other ventilator, so I've got 2 ventilators as well. One that's always just packed, ready to go. And I also have a toiletry bag, an extra one, just always packed, ready to go. So that's probably quite a good idea to keep kind of doubles of everything. Just so it's really quick, especially if you're in a rush, or the ambulance is waiting, whatever. That's probably a good idea. Yeah, especially when you may not have enough time to actually pack. So that's a quite handy trick. And normally, I'll kind of run you through the kind of admission stage. So you kind of, the ambulance is really good. Up here, I don't know what it's like in England, but up here, probably I think all of them are wheelchair accessible. So they do just clamp you in. But I was lucky enough last time where they actually said that I could just go in my own car if I wanted. So that was probably much better. It just keeps you more. I suppose it's not as much of a big deal, so it kind of keeps you a bit more confident, thinking that like it's not as much of an emergency. So probably if it's not as much of an emergency, then going in your car is probably quite good. I definitely prefer that anyway. Yeah, normally when you get there, you need. I think often they think like you don't need like your assistant with you, so I think you need to be quite firm. Because the first time I went last year, they wouldn't let my dad come with me, even though I needed support. But eventually, after a couple of hours, they let him come through. But yeah, they don't. I don't think a lot of the time they're not. The nurses really don't know the ins and outs of your actual condition, so they don't know how much support you really need. So I think it's important to be firm, to try and get your carers to go with you, or your parents or whatever. Yeah, and obviously a lot of stuff may not be used to certain conditions, like Duchenne. It's like there's a different way of kind of moving and handling. So they may not be sure on how to go about that. So it's important to try and make sure your PA's with you. One thing I think for me when I go in is I like to keep kind of entertained and I like to keep distracted. So always take in like my headphones. And obviously if I'm staying longer, then I'd try and take in like my laptop and try and like get connected to the Wi-Fi and things. I think that's just a personal thing. Like I don't like waiting around because I know there's a lot of waiting in hospital. So if you keep distracted, things like that, and your phone or maybe even like handheld, kind of things like Game Boys and stuff, or Nintendos, just to keep you busy and distracted. That's what I do. Anyway, and one little sneaky trick I normally do is try and take an HDMI. So eventually, if possible, you can connect your TV, connect your laptop to your TV, so that can keep you kind of entertained with Netflix and all of that stuff. So that's a little trick just to take with you. And probably extension cables as well do really help. Yeah, that's kind of it for me.
Great, thank you very much, Sanjeev. It's really good to hear your experience, and I think the key thing really is being able to bring your own PAs or your family in, to help you when you need it. So that's really useful. Great, thank you. And unfortunately, Flair's having some technical difficulties and is unable to join us. So we're going to move just over to Andy Rose now. If you wouldn't mind, Andy, just sharing your thoughts.
I'll follow on with that point Sanjeev just made then, and Sarah said as well about PAs coming in. It might not be something that everybody's familiar with, but most hospitals will have something called a system for a carer's passport. Now, up until a year ago, this wasn't necessarily something that people needed so much, but right now, with hospitals being run slightly differently, let's say, to before the COVID pandemic, getting people or visitors in or assistance is much more difficult. So on admission to a ward or through an emergency department, or even possibly in advance of an admission, you could contact the PALS department, perhaps to your local hospital, and get some information about these carers' passports. And what that basically says is that the person who's coming to hospital needs to have additional care input, and you are allowed to be in. You probably get a lanyard or a badge or something for your carer to wear to show they're allowed in. At the minute, it's primarily always been used for patients with significant learning difficulties or mental health problems, but obviously with staff levels being affected at the moment and wards being limited in terms of visitors, people with additional physical needs will benefit just as much as those other patients. So carers' passports, it's a thing the NHS, certainly NHS England, I assume NHS Scotland as well, where Sanjeev has a similar, if not the same system. If you're admitted to a ward, the nurse in charge should be able to help out with that. If you can do it through emergency department straight away, even better. But you could always contact the hospital in advance, even when you're not expecting to go in, and just find out what their policy is or what the procedures are for giving out a carer's passport. And that should allow the carer, PA or relative, whoever it is, to be there to support you. I think also what Sanjeev mentioned about travelling on his car is really important, whether that's wheelchairs being attached securely in ambulances or individuals not being able to sit or lie comfortably on the stretcher transport, the stretcher beds that ambulances have. So certainly in the east of England, and I know other parts of the country, London as well, and other parts, there's the option to have flags placed on the NHS ambulance trust system. So if a 999 call is made, to either a particular address or for a particular individual at a particular address, it will flag up that that person has additional needs, and then it would normally involve a supervisor for that dispatch team being involved, so that then the paramedic crew know that actually this is possibly going to be a transfer in a private vehicle with ambulance support, or it might be that they know in advance that the wheelchair needs to go in the ambulance, or there's a nippy machine coming and that sort of thing. So it is possible to get flags on the ambulance systems so that they can arrive ready, knowing what to expect for transfer to hospital. And as Sanji said, going in your own car when it's not a super emergency can be much more reassuring and comfortable and quicker than having to fight the technical issues of being secured safely into an ambulance that doesn't have the docking for wheelchairs, which I believe the vast majority do not. At the moment as well, with the COVID pandemic, we have to bear in mind that there's lots more restrictions in hospitals all over the hospital, but particularly for anything that's considered an aerosol generating procedure. So whether or not you're going into hospital for a COVID related issue, so even if you're going in for another medical illness or an orthopedic need, or even just some sort of assessment, it doesn't even have to be an admission, it could just be an assessment, maybe an x-ray or a scan or lung function test or something like that, cardiology perhaps. Anyone using non-invasive or invasive ventilation is perhaps going to be going through a new set of screening when they arrive at the hospital, because nippies and other ventilators and cough assist machines are considered aerosol generating procedure, which does increase the risk of virus transmission. And until they have confirmation that the individual doesn't have COVID, i.e. has had a negative swab, they might consider you higher risk or highest risk for spreading infection. So you might find there's a slower process for actually admission through either an emergency department or even through an elective admission. It might take longer, or even just for assessments. And so that's something which needs to be thought about in advance, and having the information available about your machine and your masks and all that is as important as Sarah was saying, having it all ready to go. But just bear in mind that right now, compared to 12 months ago and earlier, it might be a different situation, to the point that you might even not be allowed in the door until someone has found a side room, isolation room, until appropriate swabs can be taken. And just quickly, I think one of the biggest areas of support that patients can have right now is, if you've got access to it in your part of the country, is the respect form, which is being put together over the last few years by the Resuscitation Council and other specialists, which is a form that shows very clearly what discussions you've had with a health professional about what you would like in terms of your care and your treatment. So it doesn't replace things like advanced directives for refusal for treatment. It doesn't act as a do not or do resuscitate order. It just gives very clearly what your wishes are should you need any sort of intervention or treatment. Now, many ambulance services are very familiar with this, and many emergency departments and many hospitals, and having a respect form completed and filled in advance of any acute illness can save a lot of time when discussions are being had during the busy process of a hospital admission. So if you haven't seen these before, you can see them on the Resuscitation Council website, and you can contact your local, either your local NHS trust or GP practice for more information about how you can have support with filling one of those in. I've used them with a number of my patients who have been healthy and well, just in preparation for should they become unwell, and they found it a really useful tool to have there, knowing that should a paramedic crew turn up, or should they have to go through an emergency department, they can hand that over and it's recognised instantly as a relevant document, not legally binding, not something enforceable by law like some documents, but it shows the professionals that you've already had these sort of very detailed discussions and you know what you want. I think that's all I was going to try and fit in my time.
Okay, great. Thank you, Andy. So then we've got time to put questions to people about the care in hospitals. So we have one question already just around familiarity of hospital staff with ventilators and cough assists. I just wondered if that people had experience of this in terms of how well staff were able to be deal with the equipment that you're kind of bringing into the hospital.
Could I go first?
Yeah.
I think in terms of local hospitals, I haven't always been that familiar, and I've actually been glad that PAs or my mum has been with me to know sort of what it's all about. The hospital, and they obviously wouldn't know what's going on with the vents, but quite anyone that isn't specialist isn't really familiar. I went to a rehab hospital once for some wheelchair assessments, and they had nurses there that so you could have an overnight stay, but they were really worried about the ventilator, even though I explained it was very simple, sort of turning it on, turning it off, putting the mask on, taking the mask off, but they still needed training for it before I was actually allowed to go. So I think, in some cases, or whatever ward you're on or in AD, they may not have the knowledge or the confidence to know, how to use the ventilators or to sort of how they work really.
Can I add to that? I think Sarah's absolutely right. Many professionals in the hospital will not have a clue about NIPPIs or cophosis. They just simply won't have seen them. So unless you're being admitted directly to a respiratory ward or being seen by respiratory specialists within the emergency department, it's always worth asking for the on-call respiratory team to give you an assessment or one-off, so that they at least know you're in the hospital.
Yeah.
Because then if there are complications, or they need to find staff to support those, they can do that. And they may even contact the critical care outreach team. So that would be the team that specialises in trying to prevent patients getting transferred to intensive care. So again, they'll have experience with it. So if you're just not sure, or if you're not sure, the doctors around you and nurses, that if you think they're not sure, ask for the respiratory on-call team to come and see you for a once-over assessment. Then they'll have logged you in the hospital as being there, and you shouldn't then miss out. If you're on a gastroenterology ward for feeding difficulties, or if you're in an orthopedic ward or another medical ward, it's very possible people will be absolutely clueless. Absolutely, it does happen, unfortunately.
I've also, sorry.
Yeah, when I went to hospital, they really, a lot of the nurses didn't really know how to use it or anything, but we've been told, basically, any time I'm going into hospital, we just phone the respiratory ward straight away, just to tell them, let them know that we're in, and then they can do whatever's needed if the nurses are unsure. So we've been told to do that. So that's helped a lot.
That's really good to hear. Thank you. Andy, in terms of, you mentioned about the ambulance kind of being able to have notes or flag up your kind of special circumstances if they were to get a call. Like how would someone go about kind of making sure that gets recorded somewhere?
Good question. It depends on the area and who's making the request. So we know in the east of England, we can the care advisors here have got we've been given a contact details of someone we can email directly obviously with the patient's consent. I think Bobby Ansell from Muscular Dystrophy UK did a lot of work with the London Ambulance Trust, so they would be helped to give a bit more information about the process they've agreed there. If anyone's in doubt, they could just contact their local ambulance trust through their contact departments and just ask, because if they've got a system, they'll be able to find it for you. They might require a formal letter or referral or information from a GP or another clinician, but your respiratory clinic letters would probably be sufficient. So each trust will be slightly different. If you haven't got someone for example, like we've got the care advisors where I am, where we can do that for you. Then you can contact your ambulance trust directly, and they should be able to highlight the process if they've got one. If they haven't got a clue, it's probably because they haven't got a process to use.
Right, great, thank you. And just had a comment from Kath, who says she has a big yellow sticker on her BiPAP that says if she's admitted to hospital to ring this number. So yeah, that's another helpful way of dealing with it.
Yeah, I always encourage whoever's working with me to contact my respiratory consultant or whoever's on call at the time, just to get them to the liaise with the local hospital, if that's relevant.
Okay, great, thank you. We need to move on, I'm afraid, to the next section. I'm going to be hearing from James Norris from My Wishes. I'm just going to bring him up to the panelists and just swap everyone around so we can move to this next section. But I'd like to thank Sarah, Sanjeev and Andy for your excellent insights. That's been really useful to hear from you. Thank you.
Hello, everyone. Can you hear me okay?
Yes, yeah, great. So yeah, do you want to introduce yourself, James?
Yes, so hello. My name's James Norris. I'm the founder of a planning tool called My Wishes. I set up back in 2015 an organisation called the Digital Legacy Association, and we raise awareness about the importance of planning for all of our digital content, which I'll go on to speak about in a minute. I'm also a digital research fellow at Michael Sobel Hospice, and I'm a honorary design fellow at the Velindre Cancer Centre in Cardiff. So I'm going to I know there isn't much time, so what I'm going to do is throw a number of different slides at you, and then if we have Q&A at the end, that would be wonderful. So a lot of my work is spent raising awareness around the importance of our digital lives, and I do this through as many different means as possible, whether it's TV, publications, articles, etc. And I don't do anything when it comes to highlighting these areas. A lot of it is using content that's already there, and I try to reimagine it, or try to hack it, or try to reframe it for aspects that relate to care planning, end of life planning, remembrance, etc. So at the beginning of the pandemic, I was already very familiar with video streaming tools. So many years ago, for example, we streamed the pantomime Cinderella to 12 different hospices to give us short lives at Christmas. I've also, played and had experience streaming and video streaming quite a lot prior to the pandemic. So again, reframing what was going on, I wrote a very short article for the BMJ, which was all about how we can use Skype and other video calling technologies to improve conversations, and specifically due to COVID, end of life conversations, without to ensure that people were able to say their goodbyes. That kind of was then expanded to areas relating to funeral directors. So funeral director associations soon stated that video streaming was a thing. They acknowledged it, but they didn't provide any practical guides or any frameworks. So we put together a very simple set of steps that we think perhaps should be looked at and questioned, and possibly adhered to. But really, the focus of it was to get funeral directors and funeral director associations to incorporate funeral streaming or virtual funerals as part of their conversations, as part of their duty of care, should they not be able to have funerals at full capacity. This is work that's still ongoing. Unfortunately, no funeral directors thus far have adopted any guidance, but again, we just try to raise awareness in these different areas to improve conversations and aspects of care. I'm going to just do a very quick little highlight this one website for a couple of reasons. So March Madness is a festival that I'm kind of helping to support this year. Lucy Watts, your chair, actually introduced me to the people who are running March Madness, which is a charity called Festival Spirit. And this year we've got, it's the first year, but again, we're kind of using technology that's available. So in this case, again, ironically, we're also using Zoom, but we're hosting a festival with both disabled and non-disabled artists. And we've got a whole lineup of different music, thought leadership, including these two familiar faces, I'm sure, comedy, spoken word, etc. So it's free to attend, and yeah, it's happening on the 20th of March. But I thought I'd just quickly go slightly off topic. This slide should have possibly been somewhere else, but we live and learn. So the next aspect that we're going to do is we're going to look at the theory, and we're going to review two of the core words that we're going to look at following this introduction to the internet. So obviously the internet has changed many things. It's changed the way in which we communicate, and this has increased tenfold during the pandemic. Now, the term digital legacy is a term that is becoming increasingly more familiar, but ultimately our digital legacy is what remains of us digitally when we die. So it can consist of our digital footprint and things that we've created, perhaps like a blog post. It can consist of things that have been curated and published by third parties. So perhaps somebody else had written something about you in a local newspaper, and it's been published online. And it can also be co-curated. So on Facebook, for example, when you post something and then somebody comments underneath, that comment and the subsequent comments as well, that can all feed into what's known as our digital legacy. Our digital legacy is becoming increasingly important for a number of reasons. So this is a screenshot of Ben, my housemate from university, who died of adult sudden death syndrome. And his Facebook account means more to me than where his ashes are scattered. It means more to me because there's photos there. We've shared messages within Facebook's ecosystem, so I can look at those messages, and it's instant. I can immediately obtain those photos and videos. I didn't, and I still probably never will have many photos, physical photos of Ben, because when we took photos on our phones or on a digital device, we just kept them. We kept them on our own devices, and we uploaded them to Facebook. So we don't have these physical photos, these physical assets. It's moved into these digital formats, and it's becoming, our digital legacy is becoming important for a number of reasons. So for Ben, as part of the fundraising that's carried out following his death, it's helped, bring us together, but there's other aspects and other areas of somebody's digital legacy that can be created as well. So Ben played fantasy football before he died, and one of my friends, Andrew, who you can see in the chat here, thought it'd be a nice thing to create a league for him. So it's only for friends of Ben, but it allows us to remember him in a non-morbid, contextually relevant way to the people who we are, and also to the person he was. So we can talk about football, and then we could perhaps talk about Ben. It's a way in which we can kind of stay connected. But this fantasy football league now forms part of his digital legacy. And once again, this league that we enter every year means more to me than where his ashes are scattered. And according to our research, so we carry out a survey every year called the Digital Death Survey that explores society's attitudes towards death in the internet. And when we asked if somebody you care about dies, how important is it for you to be able to view their social media accounts? Now, the results are quite, they differ quite dramatically. However, you could argue that, almost half have placed some kind of an importance on being able to view, their loved ones' social media accounts following their death, because people are becoming increasingly aware, as are social networks, of the value of the content that remains and resides within them. So the second term that we're going to look at is digital assets. So our digital assets are possessions that are purchased, stored, or available online. They can consist of videos, personal videos, purchased items, personal photos, etc. And they can be located across a variety of different cloud platforms, whether they're social media sites, blogs, etc., or on physical connected devices, such as tablets, your phones, your old phones, your laptop, hard drives, etc. So our assets are increasingly being segmented across a variety of different places. And ultimately, as well as creating new content and creating and purchasing digital assets, we're also migrating what used to be traditional assets into a digital format. And we are living in the middle here. We're living in the time largely of kind of digital migration, in a time of flux, and quite often in a time of confusion. So we might be moving our videos, our photos, our money over into this digital form, but in many regards, these platforms, these ecosystems, they are developing whilst we migrate. So the infrastructure around passing on that content, passing on those assets, are forming and developing along with the migration process. So here's two photos from two family photos. These are my great grandparents. This is the only photo that we've got of them. It was taken in the Faroe Islands, which is in between Scotland and a bit of a brain freeze, Scotland and Iceland. Underneath my great grandparents is my family. So these are, this is my nan here, and all of these people here are either the partners, children, grandchildren, great grandchildren, and this was when we met up in the Faroe Islands for a family reunion. Now, the reason why I thought I'd include these two photos was just to highlight a couple of things. So first of all, if in the Faroe Islands back in the 1900s there was a social network, and this photo, instead of being printed, was uploaded to that social network, would we still have that photo today? Would that social network still exist? And would we have a high quality version? The answer is I don't know. I really don't know. That's the reason why I brought this photo in was when we attended the family reunion, it was just when digital photos were kind of emerging. So this was taken on a digital camera, and the person who facilitated this had the kind of the foresight, if you like, to take down everybody's email and to send it to everyone. Now, he did upload it to a family reunion website. However, that family reunion website no longer exists. Whether it's due to upkeep, server costs, I don't know. But this now, because we received a digital copy and we've printed it as well. So my mum printed a version, which I've got here. We've got that as a physical assets as well as it being digital. So our photos are as well as many other aspects of our lives are migrating from the physical world to the digital world. So there's over 300 million photos uploaded to Facebook every day. So we're creating this mass amount of content, but a lot of it is almost like throwaway imagery, and perhaps photos that we wouldn't want to for people to use to kind of highlight the person who we are or who we were. So this photo, for example, my great grandparents didn't have an option, but today we do have an option. So we're able to, if we want to, start addressing our digital legacy. We're able to influence it in some way, and we're able to curate aspects of it as well. But ultimately, during this time of flux, our physical assets are increasingly migrating over and becoming digital assets. At this point, it's probably worth again highlighting that there's no such thing as, and it's quite often used within the media, like a digital afterlife or a digital eternity. The only thing that there is digital longevity. So for those of you who are young enough to remember Flickr and MySpace, these two early platforms, Flickr was very similar to Instagram in many ways, and MySpace was very similar to Facebook. Now, when MySpace updated their servers and they migrated from one server to the next, ironically, they lost a lot of photos and a lot of content, and with it, the MySpace generation, that was a term that was quoted in the day, was lost, and that content was lost, and it will never be retrieved because it was all in one space in a digital format. In a similar way, Flickr, when they were no longer able to monetize the platform, photos, accounts, etc., were removed, and I don't think Flickr still exists, or those original accounts still exist. So it's important to kind of take stock and think about the content that we have, the longevity of the content that we have, the platforms that we use, access to all of these different areas, and ultimately how we can pass on those access rights to the different platforms should we wish to do so. So in 2015, I set up the Digital Legacy Association. We raised awareness around the importance of this area. We've got a number of different step-by-step tutorials that address areas such as, how to download all of your photos from Facebook and pass them on to your next of kin. We highlight how to use tools like Facebook's legacy contact, which enables you to pass on limited amount of admin rights to your next of kin or to somebody who you'd want to deal with your Facebook digital estate. And then we look at ways in which, we can use, again, this information that's publicly available to improve communication, to improve bereavement, and to improve, people's memories or their digital legacy. So if let's say, for example, Samuel L. Jackson was my father, and I didn't want to, when he was alive, be his friend on Facebook, or perhaps he didn't want to be my friend on Facebook because he's so cool and I'm not very cool. And then after he died, I was the person who had to, arrange his funeral. Now, again, this is just looking at the information that's available, hacking these areas in a very loose, playful aspect, if you like. But ultimately, if I had to organize Samuel's funeral, what I could do is go to his Facebook profile. His Facebook profile photos that he's uploaded, he has curated. He has curated them and thought, these are, these sum me up as a person. I am happy for the world to see them. So I would know that these photos could be used. They could be used in an order of service. They should be perhaps downloaded and saved and stored and backed up. We developed something called a social media will, or a digital will. This is a really simple log where, excuse me, you can visit the website, download an Excel document and log each one of your accounts and state what you want to happen to each. So it's non-legally binding, but ultimately it empowers the person who is left to deal with your digital estate to address it, and when they can, address your wishes. Now, again, it's important that each person understands and starts to become empowered about what they can and can't do on each platform. So if I was to say, I want my iTunes library to be passed on to my brother, that cannot happen, because when you purchase a song through iTunes, through Apple, you have a individual user license, and that expires upon your death. Now, however, if I was to buy the same song on Amazon, you can download it locally and you can pass it on because it's in your own ecosystem. So it's you know, each platform's got its own way of working, but it's important that we understand, you know, what you can and can't do on these different platforms. Generally speaking, as a rule of thumb, when it comes to device manufacturers, so people who build laptops, mobile phones, tablets, etc., they will not grant access to any device. So there's been a few kind of high profile court proceedings where judges have overruled this, but generally speaking, it's very, very difficult to get a device manufacturer to provide access, because they have entered into an agreement with the user to look after their data, and they do not know if you want to pass on that data in life or in death. So as part of the work for the Digital Legacy Association, we also ran an annual conference. If any of you have got and are exploring anything relating to this area, digital assets, longevity around digital content, please feel free to submit an abstract. It's streaming online this year as part of the European Association of Palliative Care World Congress. And yeah, anything that you're doing that's innovative within this space, please do apply. Which I think, let's see how much time we've got. So this leaves just enough time to quickly whiz through an innovation that we launched at the very start of the pandemic, and I'm going to give a very, very quick live demo of it. But ultimately, we launched My Wishes to try to provide a one-stop shop, a place where people can plan for all aspects of their future care, and at the same time, you know, make it as accessible and as easy to use as possible. So when you register, every person receives their own handle in a similar way to how you have a handle for Twitter or something else. So my handle is same as Twitter, James Norris. Once you've registered, created an account, you then land on the dashboard. There's a number of different resources, live feeds, tutorials, etc. Everything on My Wishes is free to use. So if you wanted to draft your last will and testament, you're able. It's form driven, so similar to the kind of form that you'd see on a online will writing service that charges you to use it, or similar to a paper form that you would kind of purchase at WH Smith's. But yeah, the difference is we provide it for free, and we use gamification, so making something that isn't fun a little bit more fun and a little bit more engaging. The way in which we do this for the last will and testament section is within the letter of wishes section. So letter of wishes is attached to your last will and testament. It's a non-legally binding set of wishes that is provided to your executor, so it could be your partner, your parents, your children, etc. And items can be allocated within this list. Now, for Chris Connell, for example, I've got a cowboy hat. It's of a very low monetary value, but it is of high sentimental value. And what I'm able to do is post onto Chris's Facebook timeline that I have just allocated Chris Connell this item within my last will and testament. So again, it informs him of it. It's a little bit playful. It's similar to the gamification mechanics that Facebook brought in many years ago, when you could buy virtual flowers for someone. I'm going to largely skip past the funeral wishes part now and go, because today is mostly on care planning, and go straight through to the advanced care plan part. Now, as was mentioned earlier, there's a number of different legally binding forms. This advanced care plan is based on your wishes and your preferences. It's not legally binding. You do reference, and we do click out to the relevant forms in terms of organ donation, refusing treatment, LPAs, etc. But ultimately, it's you state what you would and would not want to happen. And then once you've completed it, you download your advanced care plan. You can email it directly to your GP, who can then append it to your medical records. You can print it and keep an item as a version, locally. And you've got a digital version of your ACP ready locally and also online. Now, as part of this, we a couple of months ago, for the health hack in Wales, a physiotherapist said that in Wales, postural care plans are quite often not available when somebody's admitted to hospital. And she wanted a digital version, or for it to be digitized. So we've added a section where, if I go to postural assessments, so if you have a postural assessment carried out, you can upload the PDF or an image of the postural assessment. You can also include videos, so to give further context, and add a memorable word. Now, going back to what I mentioned earlier, that everybody has their own vanity URL, what we can provide is rapid access to that postural care passport should it not be available in an emergency. So I'm going to get rid of that and go to my vanity URL. So as you can see here, it's /James Norris postural care, but it's just comes off of the main vanity URL. I've added, in this case, my memorable word or phrase. So in an emergency, that can be added and entered, downloaded, and you've immediately got the postural care passport with any of the details that's required. So when we're on the public page, I may as well show the other non-sensitive information that can be published. So again, if you wish to make your URL public, if you want to create a bucket list, you can create a bucket list. If you want to, like in my circumstance, my funeral playlist is very important. You can state and publish your funeral playlist. You could leave goodbye messages if you want, and schedule messages for the future. So I've scheduled messages for my brother's birthdays, for example. And I'm able to kind of say goodbye online, just as I might be able to say goodbye in the real world. So I'm able to say goodbye in my own time, in my own way. I've kind of demoed and shown most of the innovation now, but I think I'm just going to conclude with the staying on and going back to the digital legacy side, and just quickly scanning through the digital will section, in a similar way to how it's important to make plans for your physical items, it's now becoming increasingly important to make plans for these online accounts and our online lives. And this is a very simple, very similar to the Excel document from the Digital Legacy Association. You just select all of your different accounts, you state what you want to happen to each, and it's broken down by verticals as you scroll down. As and when they're saved, they're added on the right hand side here. I forgot to mention that if you want to work in full screen mode or whatever, you can do that as well. But anyhow, when something falls outside of these verticals, you can put it in my other accounts, and it will be listed in other accounts. So for me, I've got a PlayStation account and I've got Bitcoin held in Coinbase. And ultimately, what this allows you to do, again, just like the will, just like the funeral wishes, just like the advanced care plan, etc., you're able to download the document locally and email it to someone, print it locally, so you've got all of that content both in the digital format and in the physical format as well. So I'm going to just conclude now with a few last slides. So there's a learn zone area on My Wishes, which has got a number of different tutorials that kind of helps our users and our community better understand different areas, but then also to understand the different features on the platform. And this includes, things such as, animation step-by-step guides for arranging a funeral online, perhaps, or then again, making the most out of the bucket list. And I'd like to set one piece of homework, should it be of interest. So when it comes to documenting your social media will, there's two options listed here. You've got the My Wishes online version, and you've got an Excel template that you might want to use. So when it comes to thinking about these areas, they're becoming increasingly important year on year, and finding ways to pass on information, finding the ways to have conversations, and finding the ways to ensure that assets are not lost is becoming increasingly important. If you want to get in contact with me at all, my details can be found here. I'm at James Norris on Twitter and at James Norris on My Wishes.
Great, thank you very much for that, James. Very interesting. And we will have a chance to take some questions now. So we got one question already from Mark saying, "How do you donate your body to medical science?" I wonder if that's something that you looked at.
So you can it is quite popular. It's not it's not something I know too much about, but I know that you can contact individual medical institutes, and they will work with you and your family to make sure that your wishes are adhered to. And I believe there's also a set, they will help provide costs for the funeral ceremony. I think it's maybe a year and a half or 2 years later as well, to help support you if you want to. But it's not that's not an area really. I'm mostly specialised in kind of the digital side of planning.
Okay, great, thanks. I had a question as well, just in terms of the advanced care plans that you were talking about. I just wondered, I mean, I don't know much about the different formats that these might take, but I just wondered, will this be kind of recognized by doctors and used, or will they have their own kind of format that they need you to complete, as well as doing like using the My Wishes tool?
Yeah, so I mean, there's a number of different advanced care plans. So different hospices have got their own advanced care plans, different regions. There isn't a standardized set of questions, and this is like a standard advanced care plan. So it's your preferences. Now, they're not legally binding, but it will articulate what you want to happen should you not be able to articulate your wishes yourself. There are forms, some of which were mentioned earlier, so DNA CPR, which is legally binding, and LPAs, lasting power of attorneys, which are legally binding. But and then you've got, again, respect form, which isn't legally binding, but it's got a little bit more weighting, if you like, because it's carried out with a healthcare professional. So it really depends. So generally speaking, it's this advanced care plan and the kind of advanced care plans that you get, let's say, from a hospice, takes in a lot of the wider, softer aspects. So, for example, in my advanced care plan, I've got foods that I like. I've got my belief system. I've got aspects that wouldn't necessarily be covered within a medicalized plan. It's the non-medicalized part that's largely focused, that it focuses on.
Okay, yeah, that's good. Yeah, that's good because that can often be missed out, can't it?
Mm.
But yeah, is quite important. But I also just had a question in terms of the at the end you were talking about what you could do with your different user accounts, and you could basically register your preferences on that My Wishes tool. I just wondered what are the different options, like what in terms of what you can do with the user accounts, or
So
what you can say you want to be done.
so yeah, so it varies on from a platform to platform basis, but and again, and it varies on also depending on you know, what you want to happen to the content as well. So for example, with social media sites, and there's more there's step-by-step guides on the Digital Legacy Association website, but with social media sites, for example, when you upload the content, it's not, you know, for Facebook, you can assign a legacy contact, you can provide access for somebody else to manage aspects of the account, but it's difficult to put you, and you're not allowed to pass on full access. So yeah, so I mean, it's quite hard to answer it in general, but each platform ultimately has got its own terms of service, its own way of working, and generally speaking, passing on passwords goes against the terms of service. It's up to each person as to whether or not they adhere to the terms of service or not, but it does go against their terms of service in most circumstances, and assets can't be retrieved. So it's important to think about which accounts you use. If you've got points, shopping points, if you've got things like crypto accounts, if you've got photos, if you've got videos spread across these different aspects, how can you to begin with, download them locally and then perhaps even curate them? How can you make sense of this mess? Because I, like probably many of you, have got just this kind of abundance of content that's out there, and for somebody to work out what's of value, you know, it would take them, they wouldn't be able to work out what's of value because there's just so much out there. So, you know, anything in terms of that we can do to make these aspects better and to again influence what's remains of us can be both therapeutic and helpful for our loved ones.
Yeah, great, thank you. I had a question as well about the last will and testament, and I just wondered if you could provide some reassurance in terms of using your tool. With that, you know, does that create a kind of official legal document? Is that all you need to do to kind of have that taken care of?
It is. So in the UK, for a will to be legally binding, it has to be signed, and then it has to be countersigned by two people to make it legally binding. Now, those two people cannot be beneficiaries of your estate, nor can they be the partners of the beneficiaries of your estate, and they have to there's some metric in regards to eyesight as well. So ultimately what the My Wishes does is it generates the form, it explains all of this within it itself, and then when it's signed, you know, it's done at the individual's prerogative, and it's up to them to make sure that it's you know, their wishes are clear, and that the terminology used is clear, etc. Now, we do recommend that once you've written your will, that you might get it, so you could send it to a solicitor and say, this is my last will and testament. They can then edit the PDF. If you download all of your content from My Wishes as well, it's available as a text-only version, and you could ask them for a quote. But what we don't do is, like what most online will platforms do, is they have what they call a legally binding, a legal expert. The legal expert is not a solicitor. Anybody can call themselves a legal expert, and then they will review your last will and testament as a non-qualified individual. And when they provide you with that document, it's not insured. So if there are any problems when it goes to probate, it's not insured, and you are liable. So instead of doing that on My Wishes, it's just we state, that it's up to you to check your document. We recommend, especially if you've got a complex family, perhaps if you are married or divorced, etc., things that might cause problems, that you should certainly speak to a solicitor. But rather than have somebody review it, we give you it for free, and then you can have it reviewed, or you can send it to multiple solicitors and say, how much will it cost to get this reviewed? Again, it just empowers the individual to do that themselves.
Okay, great. That's really useful. Thank you. Okay, don't think we've got any other questions. But yeah, thanks very much for giving that presentation. I think there's a lot of really useful information for people, and yeah, hopefully people kind of go and check out the My Wishes app now. So yeah, thank you. Are there any other final comments before you go? No. Okay, great. So yeah, thanks very much, James, and thank you to all our panelists today and all our attendees for coming along. And we will be sharing the recording later on YouTube, so people can catch up with anything they might have missed earlier. So yeah, thank you, everybody.